Welcome to this quick and essential lesson on permissive hypertension and ischemic strokes. In this video, you'll learn what permissive hypertension is, why it's critical, when it's used, and how to manage it safely without increasing the risk. Thank you for watching. So, as a new ER nurse, one of the challenges with stroke patients is understanding when it's okay to let the blood pressure run high. This is especially important for patients who are not candidates for thrombolytics or thrombectomy. Knowing this can help reduce the anxiety when you see elevated blood pressures being allowed. Again, this is especially important for patients who are not candidates for thrombolytics or thrombectomy. For context, the window for thrombolytics, like TPA or TNK, is 4.5 hours from symptom onset, while thrombectomy can be performed up to 24 hours in certain cases. When patients fall outside these windows or have contraindications to these treatments, permissive hypertension becomes one of the choices that can be employed. It allows higher blood pressure to maintain perfusion to the ischemic penumbra and protect the brain tissue that's still at risk from being damaged. In ischemic strokes, blood flow to part of the brain is reduced due to a blocked blood vessel. This leads to brain tissue damage and tissue death. The area of infarct or the area of tissue death has a surrounding area called the penumbra, which is also at risk for damage unless adequate blood flow is maintained. This is where permissive hypertension comes into play. By temporarily allowing elevated blood pressure, we enhance collateral circulation, ensuring the penumbra, the area around the part of the brain that has already died, that it receives enough oxygen and nutrients to survive. The goal is to prevent secondary brain injury from the hypotension or from further reduction in perfusion. As you know, if a patient is going to receive thrombolytics, having their BP under control is crucial, because elevated blood pressure increases the risk of hemorrhagic transformation. So when we are going to give thrombolytics, the goal is to keep the blood pressure below 180 to 110 before and after the administration. And if we need to do so, we use medications like labetalol pushes and nicardipine and even hydralazine. And as an ER nurse, it's going to be important for you to know those blood pressure parameters when the patient is going to have thrombolytics. Remember, 180 over 110. If they want to give thrombolytics and the BP is not that, you need to give labetalol, hydralazine, or even carding infusion, right, to bring the blood pressure below the 180 over 110 before you give the thrombolytics. For patients who are not going to receive thrombolytic therapy and are going to follow the permissive hypertension strategy, blood pressure is allowed to remain higher to maintain perfusion to the ischemic penumbra, like we talked about. Typically, blood pressure can rise up to 220 over 120 before any interventions are needed. If blood pressure exceeds this threshold of 220 over 120, medications such as labetalol, hydralazine, and carding can be administered. The management of permissive hypertension can be divided into two phases, right? The initial phase and then the post-acute phase. During the initial phase, which is the first 24 to 48 hours, the primary goal is to maximize perfusion to the ischemic penumbra while minimizing the risk of further ischemia or infarct expansion. At this stage, the brain's ability to regulate its own blood flow is impaired, making it dependent on higher systemic pressures to maintain adequate perfusion, which is why we allow the permissive hypertension when patients are not candidates for thrombolytics and could not go for thrombectomy. And then again, in the post-acute phase, which is beyond those 48 hours, we focus the shift because sustained hypertension can increase the risk of complications such as hemorrhagic conversion, which is bleeding into the area that already died. So again, if the patient is not a candidate for thrombolytics, did not go for a thrombectomy, you allow permissive hypertension. But if you allow beyond 48 hours, you run into other risks like hemorrhagic conversion. So permissive hypertension is only allowed in those first 24 to 48 hours to help save as much of the penumbra as possible. Your role as the RN is critical. You're going to monitor the patient's blood pressure closely and communicate with the team. If the blood pressure ever exceeds the safe thresholds for permissive hypertension, which is 220 over 120, you must notify the team so that it can be addressed rapidly, right? Especially with the medications that we've discussed, like labetalol, hydralazine, cardine. I want you to always verify with the team whether permissive hypertension is the plan, as certain comorbidities can contraindicate it. If we're not doing thrombolytics, if we're not doing thrombectomy, permissive hypertension will most likely occur. But again, you need to double verify with a team. So speak to the provider, speak to whoever is going to be the overseeing provider and say, hey, is the plan for this patient permissive hypertension? So that you are on the same page as the team, right? And then if you are giving thrombolytics, the BEP should be less than 180 over 110. You know the meds already, labetalol, hydralazine, cardine, that can be given to achieve that. But if permissive hypertension is the plan because the patient was not a candidate for thrombolytics or thrombectomy, the blood pressure can be allowed to go up as high as 220 over 120 to keep perfusion, like collateral perfusion to the penumbra, which is the area around the infarct in the brain that is still salvageable if adequate perfusion is maintained. And by the way, if you're finding this helpful and want to save time and energy with mastering the chaos of the ER, check out our book and course. They are packed with everything you need, including foundational material, quizzes, and practical tips to help you feel confident and prepared in the ER. You can also join the channel as a member and gain access to the course by clicking the join button. You can find the links in the pinned comment and description below.